Hi, Mike Brown. I'm a GI attending at Rush University Medical Center. I've been a professor of medicine there for the last, about 10 years or so. I actually run the training program there. And along with Mark DeMeo as one of my partners, we run our Scleroderma group. I usually am taking care of patients on the front end of this disorder with the more mild to moderate disease. Mark works with Hannah Roosevelt, who's our dietitian on the sort of end stage when we get to long-term or home TPN. Luckily, that's less and less now. If you look at my cadre of patients, I'd say 2/3 are in the area I would call mild to moderate GI symptoms, and we have not as many patients on TPN. We've done well. You know, again, I think that we've seen a decline in the number of patients on home TPN, which is always a good thing. You know, we spend a lot of time trying to make sure that we can use a gut as long as we can. There's you know, TPN sounds kind of high tech, and sometimes we use the term, you know, we're giving you this sort of high volume, high quality nutrition through your vein. The GI tract is quite elegant and does a much better job than we could ever do with TPN in the moment-to-moment sort of adjusting of what your body needs and doesn't need. So we go to the nth degree to make sure that we don't get you on TPN. So as we end up there, we spend a lot of time up front getting patients early into the system to prevent the disorders that lead to long-term TPN use. So the prevalence in the US, about 240 per million people end up with this disorder, so it's a little rare. We don't have a huge number of patients. I'd say probably in our Scleroderma clinic, maybe about 20 or 25 people we see routinely, with a few people on the outside who are doing extremely well that we don't need to see that often. Women far more frequently than men. I'd say about 80% of our clinic are women. Ages 30 to 65 seems our usual range, and the cause, as we were mentioning, is not quite clear. Obviously, this is an autoimmune disorder that affects the blood vessels, the smooth muscle, and leads to scarring or fibrosis. Unfortunately, your entire GI tract, we're just big donuts, is a tube of smooth muscle. So unfortunately, as you develop the small intestinal and the gastric and the esophageal and colonic injury to the blood vessels, this then leads to ultimately to scarring in the GI tract. So what initially happens with these blood vessel abnormalities seem to be at the root of all evil with this disorder. This then leads to lack of oxygen for the tissues. This then leads to abnormal repair, and abnormal repair is scarring. If you've ever noticed when you scar or get an injury or laceration, how the skin tends to tighten and pull together. Well, that's what you see when there's excessive scarring in the GI tract. You get this tightening, and it also stiffens the GI tract, so the motility is impaired. And the thing in the GI tract that keeps things sort of in good shape down there is motility. With regard to the stomach, or in the esophagus, excuse me, it keeps acid that likes to flow back up on a routine basis down in the stomach where it belongs. When you eat today, everybody in this room will get reflux. We all get acid reflux. We make acid, some of it will squirt back up into our esophagus, but we don't typically feel that, usually because the esophagus has very good protective mechanisms. It does a couple things. It pushes that food back down into the stomach. You increase your saliva production, whether you know it or not. When you have a reflux event, saliva production increases, and you swallow that saliva. And saliva is very protective. It's got growth factors that help heal the esophagus. It neutralizes acid. So it's actually your own built-in antacid, if you will. The valve can open and close and shut to protect you from these reflux events. What damages you from the stomach is a compound called pepsinogen. It's a digestive enzyme that digests protein. The lining of your esophagus is made of protein, so it could digest it if it wanted to. You throw some acid in there, you can activate the pepsinogen even better, and now it starts to tear up the esophagus. But if it's only there briefly, the esophagus will push it back down, saliva will neutralize it, the esophagus has great healing mechanisms and will repair itself. If that exposure gets above 4% per day, though, then you start to see some damage in the esophagus. And damage in the esophagus in patients with scleroderma is almost universal. I don't think I've seen a patient with scleroderma who does not have acid reflux and at some point hasn't had an endoscopy that showed some damage. It kind of is a subway system. It's a long tube, basically. Any part of the GI tract can be affected. That includes oral cavity. I'm glad you have a dentist here today because we see a lot of dental issues with scleroderma patients. I'm, of course, most interested in the esophagus, stomach, small bowel, colon, gallbladder, liver, etc. So long tube. So there are various stopping points in our subway system here, the esophagus being the first one. Transit in the esophagus, 10 seconds, and it's out. The main issue with the esophagus is just a transfer station to bring things into the stomach. Stomach's a different story. There things are going to spend a couple of hours. Top part of your stomach accommodates, so food goes in, it stretches out, holds food, and then slowly doles it down into the bottom of your stomach. The bottom of your stomach is like a mix master. It sort of grinds things up into very fine particles, and squirts them out through what's called the pyloric channel. So food's going to spend about 2 hours to at most 6 hours in your stomach. We like to see it less than 2 hours in there. And we'll talk a little bit some of the transfer issues in patients with scleroderma in the stomach. Small intestine, 22 to 25 feet, surface area of 4 tennis courts. So if I took the surface of your small bowel and I plated it out at 1 cell, it would cover 4 tennis courts. You can absorb massive amounts of water and fluid through your small bowel. You really don't need your colon for that at all. 22 feet of this organ that actually is usually pretty well behaved, a lot of motility, back and forth, keeps things flowing, does a lot of absorption, absorbs water, nutrients, proteins, amino acids, sugars, fats, etc. It's divided into the jejunum, top part. There's a lot of very fine little finger-like sort of processes that add to the surface area. So if you imagine you have this nice sort of plicated surface of the small bowel, and then on top of that, if you look at it microscopically, or even under the endoscope, you can see these fine little fingers. And inside each of those fingers are more absorptive glands. Unfortunately, what happens when you get some of the disorders in scleroderma, it kind of looks like somebody took a lawnmower to it. It gets cut off. So when I look in there, it looks flat and shiny rather than fluffy and sort of what we call villus-like. Then when you start to lose that absorptive area, then you can get into troubles with maldigestion, malabsorption, and end up on TPN. Things spend about 2 hours in the small bowel, so transit through there is pretty swift. Then you get to the colon. Colon's just the sewer. It's just where things are hung on to until it's time to socially acceptable to have a bowel movement. The right side of your colon, kind of a water reclamation device. Basically, it's a big sponge. We send about 1 liter of water to the right side of the colon every day. The water is basically reduced to 100 milliliters. So basically what the colon does is remove 90% of the water it gets every day from the small intestine back to you. So it's really important for water absorption. The bacteria in your colon do some good things for you, like they make vitamin K. They also break down some of the things you don't digest to keep the wall of your colon healthy. Left side of your colon, storage tank. That's where solid fecal material is held until it is socially acceptable to go to the bathroom. You get the urge, you go and you empty the left side of the colon. A little bit of absorption takes place there. Normal colonic transit time, somewhere in the range of 6 to 55 hours. When you start getting above 55 hours, you can get some pretty severe constipation. We start to call that colonic inertia. And one little area of the colon I want to mention, because it's particularly troublesome for scleroderma patients, that's the rectum and the anal sphincter. Your entire GI tract has little valves along the way called sphincters. And there's one at the GE junction, or the gastroesophageal junction. This is the one that gets us into trouble and causes reflux. There's another one at the stomach called the pyloric channel, another little valve that opens and closes. There's one at the end of the small intestine called the ileocecal valve. That one doesn't cause much trouble for us. And then there's a real problematic one, and that's the anal sphincter. And part of the anal sphincter is what we call skeletal muscle. And part of the anal sphincter is what the rest of the GI tract is made of, called smooth muscle. And it's smooth muscle that gets damaged in scleroderma. So some of my scleroderma patients have very thinned out internal anal sphincters, and this can lead to fecal incontinence. So this can be very troublesome. I don't think there's anything that socially impedes my scleroderma patients more than fecal incontinence. You can't go out. They can't go to the movies. They have to time everything. They can't be there more than a few hours because I'm going to have trouble. It's inconvenient in long car rides. It's inconvenient when you try to go to a play. It's inconvenient when you go to dinner, because everybody, when you eat, gets the urge to defecate. If you can't strengthen that anal sphincter to hold things back, it impedes your ability. And so there's an embarrassment associated with it, and it's very debilitating. So I'll talk to you a little bit about some of the new things we're doing in that area. We have an entirely new surgical clinic dedicated just to treating fecal incontinence, and a lot of the things we do there can be applied to scleroderma patients. So I'll talk to you about those things. Because I think of all the things I do, I think fixing patients' fecal incontinence does more to improve their quality of life than just about anything else we do. So our subway tunnel basically is a little more than a concrete tube. It's very delicate. It has an extremely sort of interesting complex of blood vessels, neural endings, and sheets of muscle. And the problem for our scleroderma patients is these blood vessels get damaged. This damages the nerves, so there can be an alteration in gut motility, because the nerves are the way the brain communicates to the gut, and the gut communicates to itself to continue motility. And then you can get scarring in these tissues and in the muscles that then sort of freeze it up, and it becomes stiff, and it loses its compliance, and it loses its motility. Your GI tract is always trying to move, for the most part, trying to move things downstream. So it squeezes, you ate breakfast this morning, so right now, probably in your small bowel, there are these things called peristaltic waves occurring. There are these sort of contractions of the muscle behind the bolus of food you ate this morning, pushing it downstream. And it's so elegantly designed that in front of that food bolus, it knows to relax. Behind that food bolus, it's contracting. So everything's getting pushed downstream at just the right pace. In scleroderma, nothing's happening. It sort of just becomes a stiff tube. Things almost gravity feed sometimes, particularly in the stomach, so it can be a problem. The motility in your small bowel also protects you from bacteria growing in there. Your colon is teeming with bacteria. As a matter of fact, we get into lots of trouble with antibiotics when you kill off the bacteria in the colon because they should be there. They're healthful. They are probiotics. I think you've probably heard that term. It's very fashionable now to take probiotics every day to sort of help that colon maintain a nice, healthy group of microbiota. I think when I go to GI meetings nowadays, about half the meeting is about the microbiota in the colon and how it affects whether you get obese or you don't, how it affects autoimmune disorders, how it affects diabetes, how it affects our mood. So there's a lot of discussion about microbiota. That only has to do with the colon. Your small bowel is pretty much sterile. And it stays sterile because of this great motility. It keeps flushing everybody downstream. So there's no way bacteria can set up shop in there because things constantly move. We'll talk about where that goes awry, though, in scleroderma patients in a few minutes. So the upper lower GI tract is affected in almost everybody with scleroderma to some degree. Hopefully we catch things early. We keep it on the low end or moderate end of symptomatology. You can see it in both the diffuse and limited type forms. It affects any part of the GI tract, and it can be slow or rapidly progressive. And it can affect old or young. So whether you're on the low end of the age range with scleroderma 35 or the older end 65, you can see this. So that nobody's protected from this process. Grading the GI tract is just what you might think. We have grade 0 where there's just blood vessel injury. Grade 1 we're starting to get into the neural injury and we're starting to see abnormalities in motility. Grade 3 where you're seeing muscular injury, so you're starting to lose the motility, not just from the standpoint of losing the neural input to the muscles, but the muscles themselves are not working. This is an unfortunate sort of change in the process because if the nerves aren't working, I can give you drugs that stimulate motility as long as the muscles are working. When the muscles stop working, you start getting scarring, then these prokinetic or pro-motility drugs are going to lose some of their efficacy and then on to scarring and fibrosis. So let's talk about organs. So here's our normal swallow reflex. There's a very intricate mechanism for taking a bolus of food, forming it into a blob, and swallowing it without it going down your lungs. You want to go down the right path. And so swallowing is a very sort of coordinated process. I haven't seen too much trouble with that, although if the esophagus gets scarred, particularly in the upper esophagus, patients can have food stick up there occasionally. The bolus of food is moved by those same peristaltic contractions we talked about through the esophagus. This lower esophageal sphincter I mentioned should relax. The bolus of food pops through into the stomach, and there it's going to be churned around for a little bit. A scleroderma patient who has a grade 3 erosive esophagitis, that's that valve down there. Now notice that valve's kind of frozen open. See these big cuts in the wall, these big erosions. If these are not treated aggressively with medication, you end up like the guy down here. That's a pinhole. He came in with marked malnutrition, so that basically I couldn't even get my little endoscope, which is a little bit smaller than my pinky, to get through there. So we had to open that up with balloons, which we kept increasing steadily inside to break up that scar. This is nice because this gets better very nicely on the drug class called proton pump inhibitors. There's Prilosec now and Prevacid, and all of them are over the counter. The over-the-counter ones work just as well as the ones I give you prescriptions for. The key thing with esophagitis, and we'll talk about that in a minute, is get on drugs early and stay on them in a dose that effectively controls symptoms. That does two things. It heals this issue, it prevents this issue, and it will also, this is the interesting part, reduce your risk of interstitial lung disease. I can't stress that enough. Early aggressive management of any kind of heartburn symptom, even if the endoscopy doesn't show anything, will reduce your risk of getting interstitial lung disease, which can be a disaster in patients with scleroderma. So again, don't treat this with Tums, don't treat this with Pepcid or Tagamet. Those drugs are not effective in the long-term management of reflux disease. You must be on a proton pump inhibitor. Most of my patients with scleroderma are on a double dose of the proton pump inhibitor. The only caveats with long-term use of a proton pump inhibitor are as follows. Patients who need very heavy doses of antibiotics can get in a little trouble because reducing acid can cause you to get some infections. So you want to watch that a little bit, although I haven't seen too much trouble with that. The main issue, if you're on a proton pump inhibitor, and that's for anybody in this room on a PPI, and I know a lot of people who don't have scleroderma take them for heartburn, once a year, get a magnesium level checked in your blood. There is some data recently published to show that some people get a low magnesium level due to wasting of magnesium through the kidneys on those drugs. So we check those once a year in our scleroderma patients. And if it's elevated or it's low, it's not a big deal. We just give you some oral magnesium to take. Why does this happen? Well, that valve pressure is too low, lets a lot of acid and bile salts back up in there, and they damage the esophagus. You don't have good clearance mechanisms because the scleroderma damages esophageal clearance, so you can't get that bolus of acid out of there. And then there's impaired coordination. So you want the coordination if there's a contraction to coordinate with the valve opening. If when that contraction comes down, the valve is stuck and it doesn't let it through, things are going to stick around and injure the esophagus. 50 to 80% of patients with scleroderma will get this severe reflux. The complications of untreated reflux, by the way, in addition to just feeling miserable, getting a stricture, you can get interstitial lung disease, and you can get something called Barrett's esophagus, where the esophagus says, well, if you're not going to help me, I'll try to protect myself. And it develops the lining of the small intestine. That's okay. Lining of the small intestine is pretty tough against acid, so it's not a bad thing for the body to do. Unfortunately, when you grow the lining of the small intestine in the esophagus, you have a higher risk of adenocarcinoma, a type of cancer of the esophagus. So by taking a proton pump inhibitor, taking it every day, taking an ineffective dose, you reduce lung disease, you reduce the risk of cancer in your esophagus, you reduce stricturing, you reduce heartburn and regurgitation and pain. There's no downside to those drugs. And again, you don't want to mess around with the lower level drug therapy, the Tums or the liquid antacids or the Mylantus or the Tagametes or the Pepsids. They don't do it. Got to be a proton pump inhibitor class drug. You have these contractions going on in the stomach, and if this valve isn't protective, then this stuff's going to come back up on you and get you into trouble. Not just the acid, but the bile salts as well. It's not just heartburn. You can get cough, sore throat, hoarseness, chest pain, burning tongue, excess belching. So all of these are called supraesophageal manifestations of reflux. Just like the lung disease has nothing to do with the esophagus. So when that acid comes up, if it gets down into your lungs, it's going to tear them up. The stomach is great against acid. The small bowel does a good job of protecting itself against acid. The esophagus does a decent job of protecting itself against acid. The lungs have no hope. They have no mechanism for protection against acid. Even tiny amounts, what we call microaspiration of acid and bile salts into your lungs, are going to hurt them. And they're already in danger in scleroderma, so they don't need that additional thing to kick them over. Stomach disorders, a lot of my patients have bloating, the heartburn, because the stomach isn't emptying well. That's the other complicating factor. If the stomach doesn't empty nicely, there's always this pool, which we call the gastric lake, sitting around, waiting to reflux up into your esophagus. So this is a condition called gastroparesis, stomach, paresis, weakness. And again, due to damage of the nerves, the muscle, and scarring in the stomach wall. So when we see the stomach taking long, you should be able to empty about 80 to 90% of your stomach, no matter what meal you eat, in about a 2-hour time frame. Things that slow that up are going to be the volume of food you eat and the type of food you eat. So I know we were just talking about going to McDonald's, eating a lot of high-fat food. Fats slow GI tract motility big time, particularly stomach emptying. So, you know, that was one thing about, I think a lot of my scleroderma patients would have a very tough time trying to eat a very high-fat diet, particularly due to gastroparesis, which slows things up further. The stomach should accommodate. So when you ate this morning, the stomach stretches out to take that food in, particularly the top part of the stomach, and then it slowly doles it out through the rest of the GI tract. In the small intestine, we see slow intestinal transit in almost 88% of patients. We can, if we measure that, which we can do with these new capsules and things. 65% luckily have no symptoms, so it's, you know, it's mild to moderate. There's a good motility in the small bowel, although so it may be reduced, you could still get things through there rapidly enough and do a good job of absorbing it. However, when you slow it, you can get malabsorption, you can get bacterial overgrowth. Bacteria now should be in the colon. They start to grow in the small bowel. They compete with you for your food. If you feed your bacteria, they're happy with you, but they'll compete with you. So they'll take away your B12. They'll take away your folic acid. They'll take away your nutrients, take it for themselves. So there's a competition now between you and the bacteria in your small bowel and your absorption. You get something called pseudoobstruction. This is where patients are admitted with nausea and vomiting. Their abdomen gets markedly distended because the motility acutely slows down to the point that nothing's moving through there. Pseudo meaning false obstruction. So when you do an x-ray, the bowel seems to be open, but it's just not moving at all. It's very important that patients not get operated on for this. That there's no benefit to an operation in someone with pseudo-obstruction. If you have a real obstruction, something scarred and blocking the gut, that's a different story. But most patients with scleroderma do not need operations for this. I'll show you a picture of something called pneumatosis cystoides intestinalis. When there is slow gut motility, there seems to be overgrowth of bacteria. They make gases through a process called fermentation. Those gases can get into the wall of the colon and can cause little air blebs. They can look pretty disastrous on an x-ray, but they're fairly benign. If we biopsy them, they burst like balloons. All the air comes out. Very important cause of morbidity, meaning symptoms. A big cause of malnutrition and malabsorption is small intestinal bacterial overgrowth, or SIBO. And again, this is where bacteria leave the colon, move up north into the small bowel, and again compete with you for your daily dietary intake. They also pull nutrients like vitamin B12 out of the stream and can reduce that vitamin in your system. They're cleared by peristalsis, so the more motility you have in the small bowel, the better job you do keeping bacteria way down there and keeping that area sterile. If they get in there, they'll block your nutrient absorption. They can actually damage the wall. Remember we talked about the villi. They can lead to that sort of lawnmower cuboidalization or sort of shaved off look to the small bowel. And they certainly interfere with B12 absorption. You get diarrhea, you get weight loss, bloating, abdominal pain, malnutrition, malnourishment. This can be a reason that people end up on TPN occasionally. Just to give you an idea what happens, here's your normal gut and normal motility up here. So here's the duodenum, that's the very first portion of your small bowel, very tiny, only about 20 centimeters long. And you've got your 10, 15 feet of jejunum and your 10, 15 feet of ileum. And what happens with easily digestible starches like rice or maybe the bagel you had up there, those foods will end up getting pretty much absorbed right in the jejunum or the ileum. Digestion of those carbohydrates will be complete before they get near any bacteria in the colon. Now, if you decide to go out and eat beans this afternoon for lunch, you're eating a carbohydrate that is not easily absorbed and can get down here to the colon. And when they get to the colon, the beans will be fermented and you'll get flatus, you'll get gas. That's normal. If you eat a lot of foods that are highly fermentable and not easily absorbable, all of us will get gas. Everybody in the room here today produces 2 liters of gas. Everybody has to admit to that. That's just part of being a normal human being. So everybody produces 2 liters of gas. Now, if you want to produce more than 2 liters of gas, feel free to go eat foods that will help you do that. Beans will be a good example of that, but that's normal physiology. I have lots of patients who come in and want me to change that for them, either make them not produce gas or somehow change its odor. I cannot do that for you. You can do that for you by changing your diet. Now, this is the situation in small intestinal bacterial overgrowth. You notice now that green stuff, which is where the bacteria are growing, has moved all the way up to the jejunum, to the early small bowel. So now what happens, even the easily digestible stuff gets fermented, creating gas, much less the beans and other things that are not fermentable. So you get distension, you get abdominal pain, you get bloating, you get excess belching, you get excess flatus. And those bacteria can then interfere with absorption, leading to weight loss. Motility can be so severe that it leads to an obstruction. That's that pseudoobstruction I was mentioning. You can sometimes see air in the gut wall due to loss of wall and compliance. That's pneumatosis cystoides intestinalis. Look at those little fingers sticking out. That's nice. That's a healthy small bowel that's got no scarring and is in good shape. And you notice how the walls fold over on themselves. Every one of these folds, these little fingers, increases the surface area. Unfortunately, when you get small intestinal bacterial overgrowth, that can be wiped out. And so to send in these little fingers, that little sort of fluffy shag carpet look you see in this particular image, it looks shiny and scarred. See these sausage links full of air? That's the small bowel that's not emptying well. So that's a pseudoobstruction. We don't see a cutoff point where the bowel's blocked. We just see lots of dilated bowel look like sausage links on top of each other on the x-ray. So classic pseudoobstruction, that is more common than pneumatosis, although we can see them in conjunction. The colon is involved in 20 to half of patients, mostly as constipation and fecal incontinence. There are losses of colonic contractions. We can get colonic pseudoobstruction, so here's a big dilated colon, just not moving today. Sometimes the colon gets resected because it becomes so damaged and becomes so incalcitrant to moving that we end up taking it out, although that is luckily rare. Anal rectum, I want to focus on this a little bit because I think of the things that are new and different, there's probably more in this area than anywhere else. So anal rectal dysfunction occurs in almost 70% of patients with SSC, so we see it fairly frequently. It can be due to scarring of the anal canal with outlet obstruction, constipation. So sometimes people come in with fecal incontinence because there's so much impacted fecal material in the left colon that only liquidy stuff can get out. So in that situation, you need to clear that left colon. It can be due to fecal impactions. It can do to rectal prolapse. When you lose the strength of the sphincter valve, the rectum can actually come out, and that can get in the way with defecation. Constipation is almost universal in my patients with scleroderma. Urgency, you eat and you immediately have to run away from the table to use the bathroom. Incontinence, which, as I mentioned, probably affects the quality of life about more than anything else I can think of in the GI tract, and a sense of constant rectal fullness. A little bit on the diagnostic testing, endoscopy, probably, I remember reading a statement that almost everybody in the world is either pre or post endoscopy. Sometime in your life you're going to meet up with one of these tubes, either the top end or the bottom end, or maybe even both. It's an extremely effective tool in evaluating the GI tract. It allows us to treat things, it allows us to diagnose things in a very elegant way. I even have a tube, we have a thing called a enteroscope downtown that even lets us look at almost all of that 22 feet of the small bowel, though we don't need to do that often. But we can get to almost every part of your GI tract with an instrument these days. They don't, however, measure motility. So when you have a pseudoobstruction, when you have colonic dysmotility, when you have esophageal dysmotility, gastroparesis, these are not good tools for measuring motility. This is the normal view of an upper endoscopy. There's the pharynx, you can see the epiglottis up there, and the vocal cords are back down here. What happens with the endoscope is we dive either into the molecular, we stay midline, and we pop into the esophagus. GI test, this actually is probably a little more useful actually than imaging like that in patients with scleroderma. We can actually measure the motility of your esophagus. I can measure the motility of your anal rectum. Done in our office, outpatient, no sedation required. The diagnosis of scleroderma esophagus is made by a motility study. This is Bravo pH testing. If I want to see if you're responding well to that proton pump inhibitor I gave you, I can go down with the endoscope, I can take a little button, and I can leave it behind attached to your esophagus. And over the next 4 days, it will send radio signals to a little box you wear in your belt about how much acid's in there. And that box has buttons that you push when you're having symptoms, cough, heartburn, trouble swallowing. You bring me the box back, the probe falls off and passes in your stool later on, don't want it back. And we put that into the computer, and the computer gives us this beautiful graph of all the acid events in your esophagus, and when you push the button telling me you had symptoms. So I can figure out how much acid your esophagus sees every day, and I can figure out whether those acid events are correlated with your cough, or your soreness, or your chest pain, or your trouble swallowing. So a really nice test and very easy to do. We used to have an old tube that went down people's noses. They hated that. This thing, you can't even tell it's there for the 4 days till it falls off. Barium studies, a little bit useful in making sure there's no obstruction, but we don't use them that often. They're older tests that just aren't used as much. CT scans we use a fair amount, again, making sure you don't have a structural obstruction of your GI tract. But again, they don't measure function, so we don't use them that often. Here's something we use. I call it the birthday test, because I bring you into my office, we give you sugar, and we have you blow up balloons. That's pretty much a birthday. Really easy test. We have you eat a special sugar, though, that only bacteria can digest. We look for hydrogen ions in your breath. So if we find hydrogen, that would indicate there's this bacterial overgrowth process going on. So it's our birthday test or our hydrogen breath test that we use to diagnose small intestinal bacterial overgrowth. This is EUS. The only time I really use EUS much, or endoscopic ultrasonography, or use ultrasound waves to image anatomy, is in the anal rectum. So before Dr. Favuza does surgery or tries to fix anal sphincter incontinence, we will do an EUS of the anal canal, very simple little probe that goes in there, just looks inside the wall with sound waves. And if we see the internal anal sphincters damaged or thinned out, and it's globally thinned out all the way around, then we know what kind of interventions might help you with your fecal incontinence. Electrogastrograms never kind of made it into prime time. They are a good way of looking at stomach motility, but aren't particularly helpful clinically, so we don't do them often. Scintigraphy, if we suspect that you have stomach emptying problems, we bring you in, we give you oatmeal or scrambled eggs. It has a radio label in there, and then we scan you under a big disc-shaped camera called a gamma camera. And what it'll do is you'll see these images on the screen of the stuff going into your stomach and then it leaving the stomach. And we measure how much is still in there at 2 hours. If there's more than 20% or so, we call that gastroparesis. The FDA just approved a new way of doing this with a breath test that we're going to start doing in the next 2 months. Here are my pills. I have cool pills. I have little things you can swallow that will give me all sorts of information. I have a smart pill, which is really nifty. It'll actually measure motility and give me, and at the end of the 5-day test, when it passes, I get my little box back again, and it's been sending information about where it is in your GI tract, so I can measure very precisely the motility through your gut. I measure how long it took to get through the stomach, the small bowel, the colon. Nice little tool, completely non-invasive. You just swallow the thing and bring me the little box back. And down here is a video capsule endoscopy that you probably are more familiar with. These are the colon and small bowel cameras, where you have a little television camera inside a capsule with a couple of batteries and a radio transmitter. You swallow this, you wear a little belt box, and it sends every image, tens of thousands of images, to the thing on your belt. At the end of 2 days, you bring it back, I stick it in the computer downloads the tens of thousands of images, smushes them all together in a video, and for the next 2 hours in my basement, I get to watch your small bowel go by. It's extraordinarily boring, I hate to say it, but yeah, we can, I have to have the lights on really bright, drink a lot of Diet Coke, and have a lot of music going to stay awake for 2 hours of small bowel. But then once in a while you find something fun in there. But that looks more at the, we're looking for more there. Now on that test in a scleroderma patient, we'll see that thinning out of the small bowel, but otherwise it'll tend to look pretty normal. This is the test I actually do more in the small bowel patients, looking at the motility. So treatment, and I'll finish up here, with reflux disease, the old lifestyle modifications you've heard a million times. Don't eat within 3 hours going to bed. Sit at your bed 30 degrees upright. Those are important ways of just reducing things on a lifestyle modification. Proton pump inhibitors, that's the way to go. We mentioned those. Prokinetic agents, metoclopramide and domperidone are falling out of style a little bit. Domperidone, have any of you been exposed to domperidone or heard of it? Yeah. Here's the issue with domperidone. Great drug, doesn't cause the tardive dyskinesias or the shakiness that Reglan does. The downside, it has this nasty little habit of sometimes changing one of the intervals on your EKG such that you can get some pretty disastrous heart rhythm problems. So the FDA clamped down on this drug, which was never approved in the United States, by the way, but we still used it a lot, and said you cannot give this drug. It is illegal for you to give this drug outside of what are called clinical protocols, where your heart rate is very carefully monitored. At Rush, we have that protocol in place. So if you need domperidone, if your doctor's still giving it to you, you probably should get out of that situation because that's a little risky. Get into a situation, we do it, I know U of I does it, Chicago does it, the big medical centers all have protocols for using domperidone. Get enrolled in one of those, you'll get the medication, you'll get the EKG monitoring you need, and it does work to increase gut motility. It helps the stomach empty, and it doesn't cause the neurologic side effects of Reglan. But you have to watch the EKG like a hawk with that drug. So that's the reason the FDA came down hard on that about 5 months ago. So novel esophageal treatments, we have ways of fixing that valve. We can do it endoscopically, we can do it surgically. I'll show you a couple here in a minute. We have to be a little careful in scleroderma patients because you guys just don't have that good esophageal pump. So we have to be gentle about how we tighten the valve, but we can do that. There's some new medications. Cannabinoid receptor 1s can increase esophageal motility and tighten the valve. Medical marijuana. Medical marijuana will probably, depending on what Bruce Rauner does, be approved for treating severe sort of neurogenic esophagi in the near future. So there will be a role, I think, for cannabinoids, specifically medical marijuana, in the management of severe esophageal dysmotility and severe reflux disease, because it does what you want it to do. It tightens the valve and increases esophageal motility. Transcutaneous nerve stimulators can help, and acupuncture can help with symptoms, but they don't help the esophagus move that well. These are anti-reflux barriers. This is a Nissen fundoplication, but this is the one we tend to do more often in our scleroderma patients. Rather than taking the stomach like the cuff on a pair of pants and wrapping it around your whole esophagus, what our surgeons will do will wrap you about that, like just around, make a half shoe, or sort of horseshoe shape. It's too tight to do this. You won't be able to swallow well because the esophagus is not working well. It doesn't have enough pump function to get through there. So we're going to make it loose, enough to control your reflux pretty well. You may still need medication, but not so much that you can't swallow. That would be obviously a disaster. So that's called a toupee type fundoplication, or cuffing of the stomach on the bottom of the esophagus. What we're doing is we're taking the top part of your stomach and we're making it that valve. We're creating you a new valve for your esophagus since the original one's kind of conked out. Prokinetics can help the stomach empty. Domperidone's the one I like the best, but again, caution, do it within a clinical trial. Antiemetics, anti-nausea and vomiting drugs like Compazine, Tigan, and Zofran. Other than the acid suppressive drugs, the proton pump inhibitors like Prilosec and Prevacid, I think Zofran has been one of the more spectacular drugs for us GI docs, because it really does a great job with nausea and vomiting, and those can be very disconcerting symptoms. Botox injections, there was a couple of studies showing that if you inject Botox into the valves that are too tight in some patients with scleroderma, you can open things up, but that hasn't proven to be particularly useful. Gastric pacing, again, if the stomach is really frozen up, we can give it a little electrical shocks to get it to move along, or we can give it electrical shocks that will fool the brain into thinking the stomach's empty so that you don't have nausea, vomiting. Those are rarely done. And finally, if they really have terrible gastroparesis, we put a tube in the stomach so it can vent the air out, and we put a tube in the small bowel to feed through there, but that's pretty rare. We try to control symptoms. Diet. A diet that doesn't ferment. I didn't get a chance to put it in the slides because I didn't find any data on scleroderma until like last week, but there's something called a FODMAP diet, F-O-D-M-A-P. You will find lots of information about how you can eat foods that don't ferment a lot. They don't create the gas and bloating, the distension that may freeze up the bowel and cause a pseudoobstruction. So there's one study suggesting that FODMAP diets were very useful in patients with scleroderma and reducing bloating, abdominal discomfort, etc. Octreotide, one quick comment. Octreotide improves gut motility. You can give it as a long-acting once-a-month injection. If you have GI dysmotility syndrome, particularly small bowel bacterial overgrowth, if you've got colonic transit problems, that seems to improve with octreotide injections. Just once a day injection under the skin, 75 to 50 micrograms, or if it works, you can do these long-acting once-a-month injections. So octreotide is actually, in patients with scleroderma, can improve gut motility, improve absorption, has been associated with some improvement in skin conditions as well. So I like octreotide and I use it a lot in my mild to moderate patients with scleroderma. The low-fiber diet, but I put this one up here before I found some data on that FODMAP diet. So I would rather, if you're going to follow a diet, go look up stuff on a FODMAP diet, hook up with a dietitian, tell him or her about it. I think that will do a lot to help your GI symptoms with this. Surgery, we don't do much. Remove the colon. Luckily, we don't do that very often. We don't typically have to resect the small bowel for pneumatosis. Animal studies only for intestinal pacing, acupuncture, acupressure, animal studies only. I wanted to make some quick comments about treating incontinence. Drug therapy's been okay with tricyclic antidepressants. We give a lot of people Imodium, bulking agents. Doesn't work all that great unless it's very mild. This is what's exciting. There are a couple of new things we're doing at Rush. One is called a Celesta injection. It's a neutral biopolymer that we inject into the sphincter to bulk it up. So if the sphincter's thinned out, I can inject something in there in about a 10-minute office procedure that will bulk up the valve, cause some local scarring that will actually tighten that sphincter. So that's basically a 10-minute, no sedation needed office procedure, very reasonably comfortable exam that both myself and Dr. Favuzza do at Rush. So that's usually one of our first-line interventions for fecal incontinence. But even more exciting, I think, for scleroderma patients is something called sacral nerve stimulation. Dr. Favuzza does this at Rush. Under the skin, we implant a little nerve stimulator. We run the electrodes down to where that muscle used to be, and we can actually increase the tension in that muscle to give you continence back. And of all the things we've done, and of all the new things for fecal incontinence, this is the coolest, this is the best, this is a nice intervention. Reasonably, minimally invasive surgical procedure with a high benefit in quality of life. So again, I would encourage you, if you're having any trouble fecal incontinence, see us. We'll get you into our incontinence clinic. We'll have you see Dr. Favuzza. We'll go over these new interventions, and I think you'll be better for it. So in summary, GI tract is pretty much affected in everybody with scleroderma at almost every level of the GI tract, with the stomach, I think, and the esophagus and the upper GI tract, leading to troubles with bloating and heartburn and reflux and injury. The small bowel, mostly bacterial overgrowth, and the colon, severe constipation, which can be managed with medications now. There are new ones out like Linzess and Amitiza that work well. And then, of course, the fecal incontinence through interventions at a surgical level, typically Celesta injections and sacral nerve stimulation. I don't have any treatments, I wish I did, that can halt the progression of scarring in the GI tract. I would encourage, though, octreotide as a way of improving motility, and then, of course, TPN as a last resort.